I developed the world's first interventional procedure called spinal epidural balloon decompression and adhesiolysis, and published books about in Korea and English. I also systematized the procedure so-called genicular nerve radiofrequency ablation therapy for patients with chronic knee pain, and published it for the first time in a high-profile journals called Pain. Okay, so uh, I'm delighted to introduce the new procedure, spinal epidural balloon decompression and adhesiolysis. There are two kinds of conventional epidural adhesiolysis and neuroplasty. One is chemical neuroplasty using RAS catheter. Another is mechanical adhesiolysis using Lev catheter and epidural scope. However, both methods did not have satisfactory results because they did not have effective mechanical adhesiolysis and no and ability to alleviate the stenosis itself. The balloon procedure was developed to supplement the disadvantages of the pre-existing procedure and improve the effect. The following clinical trials were conducted to confirm the effectiveness of the balloon procedure. This study on the transforaminal balloon decompression was conducted as a randomized controlled double-blind clinical trial and published in the journal Pain Physician in 2013. The inclusion criteria, foraminal stenosis, unilateral neurogenic claudication, no or minimal response to other non-surgical interventions, including epidural steroid injection. I randomly assigned the patient into two groups. With the balloon group, I inserted the balloon catheter into the intervertebral foramen and performed the balloon decompression. With the sham group, I inserted the balloon catheter into the intervertebral foramen, but did not perform the balloon decompression. The needle was inserted in a similar way as the transforaminal epidural block. Then the balloon catheter was inserted through the needle. From this point to here is the area of intervertebral foramen. A decompression was achieved through reparative ballooning and deballooning, while slowly withdrawing the catheter. Here are diagrams of the results. Leg pain, back pain, ODI, and claudication significantly improved over the 3 to 4 months in the balloon group compared to the sham. Significant improvement in claudication led to higher levels of patient satisfaction. 1 year after the procedure, about 20% of the patients in the balloon group showed more than 50% of pain relief, whereas none has been recorded in sham group. In order to confirm whether these improvements were actually made through the dilation of the marginal stenotic area, and if so, how much it actually dilates, I injected the contrast dye transforaminally before and after the balloon decompression, and reconstructed the spread pattern into a 3D image like this. From this point to here is the area of intervertebral foramen. The left image shows the before the procedure. Right image showed the after the procedure. The spreading diameter of the contrast dye in the intervertebral foramen increased by about 28% after the balloon decompression. The spreading volume of the contrast dye in the entire intervertebral foramen increased by about 98%, almost doubled after the balloon decompression. In view of these results, it can be thoroughly said that balloon decompression can expand the marginal stenotic area. There are three kinds of balloon procedure: caudal, transforaminal, and interlaminar. This is the genu catheter for the caudal approach. This is the genu F catheter for the interlaminar and the transforaminal approach. Let me introduce the caudal approach using the genu catheter. This is a video showing the overall procedure of the caudal approach. After the skin preparation, remove the inside air of the catheter and check the balloon and connect the balloon syringe filled with contrast media to the genu catheter. After local infiltration, insert the needle into the caudal epidural space. Needle has to be placed parallel to the caudal epidural space. Inject the mixed agent of lidocaine and the contrast media in order to perform the epidurogram and the regional anesthesia. The patient has a filling defect in right L5 foraminal area. Insert the genu catheter through the needle. Adjust and advance the catheter to the right L5 foramen. Advance the catheter like this. Insert the catheter tip into the right L5 foramen and perform the balloon decompression. Inflate the balloon like this. Deflate the balloon. Inflate the balloon. Deflate the balloon. Advance the catheter. And repeat the procedure again. After fully inserting the catheter tip, perform the balloon decompression while ballooning and deballooning. After performing the balloon decompression, inject the contrast media and confirm dye spread to the filling defect area. After injecting the treatment agent, move to other pathology area and perform the balloon adhesiolysis and decompression in the same way. There are some points to consider when ballooning. Stop the ballooning with the patient complains of severe pain. Do not balloon for more than 5 seconds. The procedure is a repetition of ballooning, deballooning, and moving. Lastly, move the catheter in a deballooned state only, especially in the intervertebral foramen. By using the balloon function, you can remove a broader adhesion area and alleviate the stenosis directly. So balloon plus procedures can further improve the effectiveness and reduce the recurrence rate. If you need, you can insert the epidural scope through the genu catheter. And also, it has the function to place a vein epidural catheter. So it is possible to perform neuroplasty using hypertonic saline for 2 to 3 days, just like a Rett catheter. When it comes to the target sites for the procedure, if the patient has the symptom of the L5 radiculopathy, the pathologic area is likely to be the L45 retrodiscal area or L5 foramen. So in this case, I recommend performing the procedure both L45 retrodiscal area and L5 foramen. If the patient has the symptom of S1 radiculopathy or back pain, I recommend performing the procedure only in central areas. Epidural space is divided into two parts. This line shows anterior epidural space. This line shows posterior epidural space. If you perform in the central area, I recommend performing the procedure on both sides of the anterior and posterior epidural spaces. This is a hypothesis on how to relieve the compressed nerve in the retrodiscal area using the balloon. When the nerve is compressed by herniated disc like this, insert the balloon catheter to the lateral side of the compressed nerve like this. Red spot is balloon catheter. In this state, if you inflate the balloon like this, the compressed nerve will push inward and relieved. This is how to relieve the compressed nerve in the retrodiscal area. This is a clinical example. The right S1 nerve is compressed by the right L5 S1 disc protrusion. In this case, I inserted the catheter to the lateral side of the compressed nerve, and inflate the balloon to relieve the compressed nerve. This is my technique how to relieve the compressed nerve in the lateral recess of the retrodiscal area. In fact, for this procedure, the thin and strong GNU F03 catheter is more useful than the thick GNU catheter. The retrodiscal area is very narrow space. So sometimes when inserting a thick GNU catheter, it is difficult to insert it into the narrow lateral recess, as shown in the video. Yes. It is difficult to insert it into the narrow lateral recess with the thick GNU catheter. However, like this, using a thin F03 catheter instead allows easy entry. Like this. This is a pathologic area and thin part, very thin part. After fully inserting the catheter, perform the balloon decompression while withdrawing the catheter, like this. This point is very important to relieve the L5 nerve root. In the lateral view, you can see the balloon is in the anterior epidural space in the retrodiscal area. After performing the balloon decompression, inject the contrast media and confirm that is separate to the retrodiscal area and the pathologic area. The F03 catheter can be left for 2 to 3 days to inject more medication. By tearing the sheath like this. This is appropriate to administer hypertonic saline for after the balloon procedure. In the normal intervertebral foramen, rubber should move freely like this. However, if there is stenosis, adhesion would be accompanied like this. So if possible, the catheter should be inserted into the upper side of the foramen where the nerve passes. If catheter is inserted into the lower side of the foramen like this, you may be unable to remove the adhesion around the nerve properly. The two different entry angles are marked with color. I recommend entering at the purple angle. Balloon expansion in the intervertebral foramen has the effect of not only alleviating stenosis, but also removing adhesion. This is a video showing inserting the catheter into the left L5 foramen. Adjust and advance to the left L5 foramen. Insert the catheter tip to the left L5 foramen like this. Perform the balloon decompression while ballooning and deballooning. After the balloon decompression, inject the contrast media and confirm dye spread to the treatment area. After injecting the treatment drug, move to the left L45 retrodiscal area and perform the balloon procedure in the same way. After then, inject the contrast media and confirm dye spread to the treatment area. You can see dye spread to the anterior and posterior epidural space. If you perform in the center area, I recommend performing the procedure on both sides of the anterior and posterior epidural spaces. Catheter is in the anterior epidural space. Catheter is in the posterior epidural spaces. You can see the difference. This is a video showing how to insert the catheter into the anterior epidural space. In the lateral view, stick to the catheter tip to the frontal wall of the epidural space as much as possible, like this, and advance to S1 2 level. And in the AP view, adjust the catheter tip to the medial and advance to the pathologic area. And in the lateral view, we have to confirm the catheter is in the anterior epidural space. If the catheter is in the anterior epidural space, you can perform the balloon adhesiolysis like this in the lithotritical area. After performing the procedure, inject the contrast media and confirm the dye spread to the anterior epidural space. If you see the AP view, so you can see dye spread to the center area. This is a video showing how to insert the catheter into the posterior epidural space. In the lateral view, insert the catheter, follow the posterior wall of epidural space, like this. Advance to S1, S2 level, and in the AP view, adjust the catheter tip to the center and advance more to the target area. Fully inserted in the catheter, perform the balloon decompression, balloon adhesiolysis, while withdrawing the catheter, like this. And inject the contrast media and confirm the effect spread to the center. In the lateral view, confirm the dye spread to the posterior epidural space. L45 and L5S1 retrodiscal area are common site occurring adhesion. Therefore, it is important to treat the retrodiscal area widely. This is a video showing how to remove adhesion in the central area as wide as possible. Move the catheter tip from side to side like this. You can perform the balloon decompression even in a patient who has undergone interbody fusion. In the lateral view, insert the catheter to the anterior epidural space. And in the AP view, advance the catheter carefully, sometimes using the balloon. You can see the filling defect in the central area. Advance the catheter carefully, sometimes using the balloon, like this. Sometimes using the balloon. After fully inserting the catheter, perform the balloon adhesiolysis while withdrawing the catheter. After the procedure, inject the contrast media and confirm dye spread to the treatment area. In the lateral view, you can see dye spread to the anterior epidural space. This is the balloon. In the case of interbody fusion, you can perform the balloon procedure only in the anterior epidural space. You cannot perform the posterior epidural space because of severe epidural fibrosis changes. After balloon procedure, neuroplasty can be originally performed by leaving a thin epidural catheter, as shown in the picture, at the lesion site and injecting hypertonic saline for 2 to 3 days. This is a video showing how to leave a drug injection catheter after balloon procedure. Insert the drug injection catheter through the gene catheter. So after then, remove the sheath and remove the gene catheter while leaving the drug injection catheter in the target site. And after then, adjust the tip location of the drug injection catheter under the CM and inject the contrast media to confirm the thick catheter is gene catheter. And remove the gene catheter. You can see the drug injection catheter and adjust the catheter tip location. After then, inject the contrast media and confirm the catheter tip location. Confirm the catheter tip location, like this. That's the tibia here. This is a picture that the drug injection catheter fixed in the skin. We conducted this 1-year follow-up study. We performed a balloon procedure on all kinds of refractory spinal stenosis, back pain, leg pain, ODI. All parameters improved continuously throughout the year, compared to other non-surgical interventions whose effects tend to be reversed after 3 months. Balloon procedure using the genu catheter improves the working ability, which may promote longer-lasting effects. We conducted the randomized prospective multicenter study involving 3 department doctors in 7 hospitals in Korea. Anesthesiologists and neurosurgeons, orthopedic surgeons participated in this study. A total of 317 patients were enrolled and published in the Journal of Clinical Medicine in 2019. The nature of multidisciplinary, multicenter studies risks the variance in the procedural methods that could significantly influence the study outcomes. To minimize this possibility and maintain objectivity, the study was conducted in a novel way. Once the target sites of the procedure were determined, balloon procedure was performed at every site. Upon the completion of the procedure, the success or failure of the procedure was marked, as shown in the figure. Target areas were marked based on successful ballooning and failed ballooning, F. The markings were then used to calculate the success rate. 3 out of 5 targets are successful. The success rate is 60%. Leg pain, back pain, ODI, all parameters show the same result. Please see the graph. When the success rate was more than 50%, like 2 lines, pain and ODI were improved continuously throughout the year. However, when the success rate was less than 50%, or 2 lines, the rate of improvement tended to decrease over time, like this. These results mean that at least 50% of the suspected lesions must be completed by balloon dilation to have long-term improvement effect. These results indicate how important the success rate of the balloon procedure is for long-term improvement. When it comes to the let me introduce the transforaminal approach using genu catheter. This device is suitable for single-level and localized foraminal lesion. The most important thing for the transforaminal approach is to place the needle as flat as possible to the intervertebral foramen in order to insert the catheter without resistance. First, you have to find the maximum oblique view that you can insert the needle into the intervertebral foramen, like this. In this state, the red spot is the insertion point. Insertion point is infralateral of the frame. This is a video showing the overall procedure of the transforaminal approach. This is the insertion point. Insert the needle in the same way as the transforaminal epidural block. However, you have to insert the needle as flat as possible to the foramen. Insert the needle until the needle tip is reached the anterior epidural space. When the needle tip is reached the anterior epidural space, the tip is in anterior epidural space. Insert the GNF catheter through the needle, like this. After fully inserting the GNF catheter, perform the balloon decompression while withdrawing the catheter. From this point to here is the area of intervertebral foramen. So main target site, balloon, and the balloon, balloon, and the balloon. Repeat 2 or 3 times, 2 to 3 times. After performing the balloon decompression, inject the contrast media and confirm dye spread to the treatment area. If the balloon does not complain of severe pain, it is good to inflate the balloon as large as possible. The larger the size of the expanded balloon, the better the effect. If the maximum oblique view, if maximum oblique angle, you can insert the needle into the intervertebral foramen. In other words, in this angle is less than 30 degrees, the transforaminal approach is not possible. You have to use the interlaminar approach instead. There are 2 kinds of interlaminar approach, retrograde approach and same level approach. The GNU F03 catheter is suitable for interlaminar approach. First, make an optimal hypothetical line through which the catheter will enter using the needle. The intersection of the optimal hypothetical line and the midline of the pedicle is the insertion point. The blue mark is the insertion point. This shows retrodiscal interlaminar approach. This shows the same level interlaminar approach. The choice of either procedure is determined by which level of interlaminar is wider. This is a video showing the overall procedure of the interlaminar approach. First, you have to find the insertion point like this and insert the needle into the interlaminar space at this angle toward the foramen. While this is a video showing the overall procedure of interlaminar approach. At first, in the AP view, you have to find the insertion point here. Insert the needle into the interlaminar space at this angle toward the foramen, while finding the epidural space using LOR technique. After finding the epidural space, insert the GNF catheter like this into the foramen. After fully inserting the catheter, perform the balloon decompression while withdrawing the catheter. In the lateral view, You can see the balloon is in the anterior epidural space. Repeat this procedure 2 to 3 times. After performing the balloon decompression, inject the contrast media and confirm dye spread to the treatment area. Best indications, in my opinion, are claudication or radical path caused by mild or moderate stenosis, perineural adhesion caused by chronic degenerative disc disease, short duration, less than 1 month, to other conventional interventions, for example, steroid injection or the neuroplasty. Some people are concerned about nerve damage from balloon expansion. According to the review of a number of published journals, it is safe to expand the balloon slowly. The balloon compression of less than 2 hours does not cause damage to the nerve. For the balloon procedure, it is advised to expand the balloon for less than 5 seconds and to stop the ballooning if patient complains of severe pain. So if one abides by this advice, nerve damage should not be a major concern. Since balloon procedure was certified as the newest medical technology in Korea in 2013, it has been commonly used in most large and university hospitals. Recently, I have obtained CE certification and is exporting to Singapore and Italy. I personally have more than 9,000 clinical experiences so far, and am very satisfied with the effect of this procedure. So far, 12 SHI articles related to the balloon procedure using gene catheter have been published. Recently, I published a book contains everything about this procedure. I'm sure this book will help you to understand this procedure in detail. You can buy this book on Amazon or Spring homepage. Thank you for your attention.